Greetings, friends and followers. This is Nurses Talking, and I am Del Barcy. And as always, if you like what you see and hear, subscribe. Leave us a comment. Let us know what you think. Here on Nurses Talking, we speak to nurses anywhere in the world and at any stage in their nursing journey. Today, I have the very great pleasure of welcoming for the second time Irene Soirassot-Joseph out of New York. Irene is a nurse with more than 20 years experience. She's a former Joint Commission surveyor. She says she's passionate about staff development and she's an entrepreneur. She's founder of ILS Care Regulatory Solutions, and she's going to tell us all about that. So welcome, Irene.
Thank you, Dale. Appreciate it. I'm happy to be here a second time
I'm,
too.
yeah, right. I'm happy to speak to you for a second
Yeah,
time.
yes.
I think
Different.
it was
And
about a year ago.
yes, it was a year ago, and a lot has changed in that last year. So I'm excited to be here again. Thank you so much for having me.
My pleasure. All right. Well, you're going to tell us all about these changes. But I wanted to start by asking because I said, I said you're more than 20 years experience, Joint Commission surveyor and all of that. But I know that you began your career as an LPN, they eventually became Joint Commission surveyor. And so I want to know what kind of along the journey, what kind of moments shaped how you see nursing and quality today.
Um, the, funny, so it was a moment of unexpected moment. It was something I always say there are ways that sometimes where your path completely changes in a
Mm,
moment. And my moment was a phone call. And to this day, I'm so grateful to my then chief nursing officer, who at the time I probably could have been upset, but she changed the whole trajectory of my career. It
mm,
was a phone call to go and help navigate a surveyor. And I remember when she called me in my office. I mean, I live in Queens. My office is in Queens. She called me. I had to drive out to Long Island to help navigate. We was just getting surveyed. She needed someone to help navigate the surveyor through the system, their EMR, which is this
mhm.
is what I thought I was going to do. This was my first ever survey as a leader. And then I went in, walked in, and I tell this story because I walked in with a pencil and paper. And it's a key thing here is pencil and paper because I thought I was gonna go in and help navigate the EMR because I know where things are, plan of cares, different things. And I walked in and the surveyor, I started to navigate this is the system for her. And she was asking questions. She wanted to see different areas of the patient's chart. And then she started to ask me questions about the chart, and about orders and visits. And like I could feel myself sitting up straight because we went from, I'm just gonna tell you, when I tell you, Miss Dell, I had my phone and I was just gonna help her. You want to see consent form? Here it is, and just sit there and look at her. Had my phone because I was still, managing my team. And then she said, "Oh, so I see there's a Foley here. I'm not seeing an order. Can you please tell me what's going on here?" My spine, I start standing up so straight. And instead, I could have easily ran away, but
Mm,
I was intrigued by some of the questions she was asking. She was asking things, not just this specific Foley question, but just different ways of how she was looking at the chart when it comes to patterns, when it came to the way we cared for the patient. Different areas of the record, how she was linking the plan of care to the visit note, how she was looking at orders and not just the technical things, but just the story itself. Can
mhm.
we, from what she was reading, can we, can you tell why this patient is on hospice? And those were the questions she was asking me. And she then went on and was educating me on the findings. And I tell you, it changed my whole how I saw nursing, hospice nursing, I think nursing in general, how I saw documentation, how I saw assessment, how I saw compliance itself. I went from someone who was afraid of it. When you heard surveyor, it was just a fear, your heart dropped. And then I embraced it. And since then on, I got very invested into knowing, wanted to know more. I said to myself, I will become a surveyor one day. And during my tenure there, during the time I was there in the agency, I changed how we saw plan of care. I started teaching other nurses how to see plan, how to document plan of care. I became the expert go-to plan of care at the time. And this is, I could say this is the time where my love of compliance and survey documentation, helping nurses, have nurses understand why certain things are being done, and never be afraid of what the rules are. And to me, I see the rules as a blueprint. And the
Yeah.
reality of it is that they're not perfect, but if you understand even just the basics of what the rules are, you really could do extraordinary thing in your organization.
Yeah, yeah, yeah. So I have two questions. One of them is that you just led into what the second question was going to be, because I was going to ask you about that fear that an apprehension that people get the minute they hear the word survey and compliance.
So it's really meant to protect three things. Of course, number one is the patient. That's
Mhm.
really that. Let's start with that. And we need to see ourselves, because sometimes we only see ourselves as nurses and as people who care for others. We never see ourselves as we also could be the patient. So
Yeah,
we need someone, if those rules are there to protect the patient. But essentially, if used and understand properly, it protects the nurse too. And it protects, of course, the organization. So compliance is not a punishment. I know we see it as punishment. We see it as I'm gonna catch this nurse. And I know that's how it's framed usually,
yeah,
right? When a correction is being sent, you kind of feel like you're being criticized. But compliance is really proof of care. It's there to make sure that we're providing consistent care, and that it really protects everyone. And I think nurses sometimes we get very offended when or start really get upset and I mean, even what I do now, I get nurses who really get offended when we send out a correction after we check certain things. But the reality of it is, if QA didn't exist, if an organization is not QAing or reviewing records, there's a lot of nurses, believe it or not, that could really have lost their licenses because of it. So it's a good thing that someone else outside is looking at your record and able to pinpoint to you, listen, this is please elaborate more on this blood pressure of 200 and 105 that you have no documentation of calling the doctor for.
yeah, yeah, yeah. And that comes back to that thing that we always say. And somehow we say it, but it just kind of goes overhead that we say if it wasn't documented, it wasn't done.
Wasn't done.
Right? And
It's
it
so
just doesn't
true.
mean that they probably didn't do it, but you have no proof that you didn't do it.
It's so true. And we need to
Yeah.
reframe it. Really, I'm telling you, it's the way we're seeing it. It's not, it's there to protect the patient and
Hmm.
you. So there are times when when a QA person is catching something. I know it's difficult because no one wants to go back and make any corrections. Like I wrote what I wrote, and I understand if someone is sending you correction back on, oh, you didn't capitalize the letter A.
Yeah.
I get that. I get you upset about that. Like, are you really, are you serious? But there are times that I have seen documentation written by nurses copy pasting over time, over, copying, like you saw these patients yesterday, 2 weeks ago, you come in, it's same thing over and over, being repeated. And then someone says to you, you know what, your notes are looking exactly the same. can you please reframe and go back and look at your assessment and rewrite some of this? Because it's good that we're saying it and not someone else. It's better that I'm saying it. It's better that you're upset with me than being sitting in court somewhere and now
Yeah.
you have to explain yourself.
Yeah, exactly.
Yeah.
Exactly. Exactly. So this is what you're talking about when you talk about confident documentation.
Yes. Yeah.
Yes. So that's what it looks like in practice.
That's what it looks like in practice.
When your chief nursing officer called you to come in and navigate this first, what was your role at that time?
I was a manager. I was managing a team of 110 patients. And I believe I had about, I'm going to say 8 nurses, LVNs, RN, 8 staff. So discipline, a
Yeah,
whole team and a whole IDG team.
yeah.
Yeah, I was a nurse manager, and they felt confident to ask me because we maybe couple of months ago, a few months prior, we actually started. We had a brand new EMR that we switched over,
Mm.
and me being I'm a fixer. I'm a problem solver. So
Clearly.
when we got the new EMR, I created a cheat sheet for myself because in the steps on how step one, step two, click here, click there, and I decided to just share it with the whole company. And then I became the EMR guru.
The
And
go-to.
the EMR guru. So then this is why I was called. I was not necessarily called to go and defend record, but I was called to help because I knew the EMR, but then ended up defending the records. And I
Mhm.
can tell you, the surveyor at the end, really at the end of the survey, said to them that I had done such a great job that the reality of it is the survey could have gone so bad if I didn't really defend a lot of the things that she was finding. So
Mhm.
we could have gone into really, really bad condition level
Bad stuff.
situation. So, but because I was able to explain how we do things and really kind of help in I don't even know what to tell you at the time, but I was able to defend. I was able to defend us, and it was it was great. And from what I learned, and the key thing afterwards is that the time that I spent with her, I was able to take all of that and teach the whole organization. Now, this is a huge hospice in New York and I will not be named, which I will not name, but the people
Right.
that know me knows what. So I was able to take that and really help educate the team at the time. And we
Mhm.
were able to implement a lot of the things that I learned. And we were able to teach everyone and really help with how we QA and how the education was done afterwards, understanding plan of care, and then be part of that correction plan. So it
Mhm.
it was it was really good. And for me, changed my whole trajectory of my whole career changed that day.
Excellent. And it's amazing how things happen like that. You know, you wake up one morning having no idea
No
that
idea.
this is going to be the day that
No,
changes everything.
no. If I at that moment I did not believe that me right now would have my own company, help doing, providing QA service, providing QAPI service, helping agencies. Like I'm at the level now where I am helping with ADRs, like major issues where I've helped several agencies go through several audits,
Mhm.
high level audits, level one, level two appeals, from beginning, getting them removed from CMS's probes. So
Mhm. Mhm.
I have done a lot ever since. So I'm just to think this is where it started. Even speaking to you about it now, I'm like, wow, we've come a long way. We've come a long, long way.
Good. Excellent. 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 So just to countersink your point, kudos to that CNO who knew who to call.
Yes. Yes. Oh, she was amazing. She was a great mentor too.
Okay. But anyway, from a leadership standpoint, um, would you say that poor documentation, what kind of effect would you say poor documentation has on like staff morale, for example?
So it really, it's burnout. It burns out the staff because the nurses constantly have to make corrections. But the
Yeah.
bigger issue is education. Poor documentation, I'm gonna say, is rarely a nurse problem. Let's take that out of it. It's not a nurse. Poor documentation is not a nurse problem. It's
System.
a system and education problem. That's what it is. It's a system and education problem. Sometimes we blame the nurse for the poor documentation. No, I mean, it's the
It's
system
really
and
why
the
I'm asking that
education.
question, actually, because the nurse ends up being the one getting the blame when it's
No, it's the system. Because the first thing I usually ask the organization is show me any proof that you've educated your nurse on hospice eligibility. And we're not talking about multiple PowerPoints and sitting there. We're talking about actual scenarios. When I do education with the team, so I will do so some agencies when they sign up with me, part of the package is of staff development and staff education. And I will do part of it would be like maybe a two, three slides of hospice eligibility. These are things they've heard. They know this. They know what it's been in their head, but no one has actually ever showed them to take the assessment, right? Because the documentation stems from your assessment.
yes.
That's where it starts. It does it because I think sometimes we separate it. We separate like narrative
Mhm.
writing, right? Shift, whatever it is that you're writing, the narrative that you're writing comes from the air, come from it comes from your assessment. So in hospice specifically, it's what you're assessing. What were your findings? That is what you're now writing as a summary
Yeah.
to let us know what's going on with the patient, what you observe in every patient, whether it's home health or hospice, because they each have their own rules on how, whether it's homebound, medical necessity, or for hospice eligibility, terminal diagnosis. So your assessment, right, starts from how to assess those patients. The way you assess a home health patient, you do not assess the same way for a hospice patient because
Word.
every single time the hospice we're looking for a decline. Home health we're looking to see if the patient is getting better. Do they still need to, you know are they went for surgery? Is the wound healing? Is all of
Yeah.
that? Hospice
Yeah.
will like, is it not eating? Is it not drinking? Or they, if it's depending on their diagnosis, different things are being looked at. So it stems from
Yeah.
your assessment. So when we're educating nurses on how to write, on how to document, let's go over how do you assess? How is the assessment first, and how do we take this assessment, convert it into a narrative? So
Mhm.
that's what it is. So for me, when I educate, I do scenarios where I give you a full scenario of a patient, and I even do you're the auditor, because nurses also, you should see how nurses they're able to tell you, oh, this is wrong, that's wrong, this is wrong. So I'm like, if you're able to tell me everything that's wrong with the note, then you're able to document accordingly, because now you're able, and then there's always a aha moment of, oh yeah, I never thought about that. Because you need to audit your own chart. So if someone else was reading this record, reviewing this record, what is it that you would pinpoint and say what's wrong? What else would you add to it? What would you remove? How would you reframe the sentence so that it can show that there's a decline? So again, poor documentation is not a nurse problem, it's a system and education problem.
Yeah, 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 yeah. And you just articulated, excuse me, very eloquently why QAPI is not an abstract
Yes,
issue. It's a very,
yes, yes.
by the way, le- you and I both said QAPI, but we should really say exactly what that is because that is recognized that not everyone who's listening understands what we mean about. So what is QAPI?
So QAPI is Quality Assessment Performance Improvement.
Right.
Um,
Okay.
so what it is in layman terms for all of us to understand. QAPI. So there's QAPI and then there's QA. It's quality
Mhm.
assurance when you're checking the chart, everything that's going on in the record with the visit today. QAPI, the way I explain it, it's like it's your own internal surveyor. That's what QAPI is. It's your
Yeah,
internal auditor, your internal surveyor. Because what you do is you're looking at pattern and you're making sure what you're finding, there's actionable correction put in place to
right.
fix the problem. So
Right.
that's
That's where the
what QAPI
performance
is.
improvement comes
Yes,
because
that's where it comes.
otherwise, why'd
Yes.
you do it?
Yes, and I think that's and if used, I'm telling you, if the QAPI was being used for what it was, for what it is, it would be such a fantastic tool for a lot of organizations. Because you see the things. If you're seeing multiple times that your consent are not being signed properly, there's missing checkbox and lists and things. And those technical things can get you a denial.
Yes,
Yes, yes,
at
those
best.
technical it can get you, and then we didn't even get to the fact that to see what was documented. We're talking about just like they open it up, consent form. Oh, just a checkbox. And when I say this, I'm like, people don't understand a checkbox because that whole consent form has several tags on it. A whole consent form can have 15, 20. I could go in and find 15, 20 deficiencies on just one consent form. So you cannot have checkbox. So part of my services I provide is QAPI. Part of it is where we do those technical um, reviews, and you should see from the pulse, from the consent form, check boxes, things not being checked. So now let's say you're seeing those pattern, and you do, and the correction is speaking to the nurse whoever's collecting the consent form. There is someone that needs to upload this consent form into the record. So this we have two layers before it actually ends up in the chart. Two people gets to look at it: the person who's collecting it and the person who's uploading it. So so now we could they're right there we could it's easy to find where our gaps where our problem is. So you need to educate. We need to show them what a proper consent form looks like, and what not the one with the errors look like, and why. Because I think sometimes the why is also always important, because
Yeah,
I think the why makes everyone remember why, the reason why they need to do things. And
yeah.
then we're also talking about face-to-faces, certification that has the wrong date. So many things in the technical that you in QAPI, it helps your system, even with the how we document incomplete visit notes, monitoring the correction, how many corrections are going back and why so many corrections. So, and then keep track of it. Did we see like each quarter, are we seeing less and less? Are we seeing more and more? And then you could take all of these patterns and really educate the staff and use all of the data that's being collected to the benefit of the organization. But because it's a requirement, it's
Mhm.
used for that. As long as we have the data collected, we see it, then
Yeah,
yeah.
yeah, yeah. And for that is if you're doing that, that data is not really abstract or foreign. It's collected
No.
from your own
From
organization. You could
yes,
basically to
yes,
emotionally identify with this.
yes, yes.
Yeah.
But from my experience, I see there's a lot of what I do mirrors. It shows. I come in, and when I when we, because I'm in I'm an outside QA service. So
Yes.
with that, unlike when you're internal, because I've done internal QA, and internal QA, we're very you're always questioning. Not every, and I say this to a lot of owners, and leaders, and I say to them, sometimes when it's an internal person doing it, there's a little bit of a conflict. And the reason there's a conflict is because it's your fellow nurse that you're getting ready to say that you did this wrong, or this is not being oh, here's all the
Yeah.
errors that we found. So sometimes, and I'm not saying all the time, but I know that conflict because I've been there When
Mm-hmm.
because then there's the nurses push back to you, the nurses gets upset, people are saying, why are you sending this back to me? Why so many errors? And of course, you have one person who's probably doing QA for your whole organization.
Uh-huh.
And
Been
that's a
there.
lot of work for one person. And there's so many areas that you need to look into. And you don't, that one person cannot see
Yeah.
everything, cannot touch everything for you. So comparing to me, when I come in, I have a team. My company is divided into two. We do the quality assurance where we're doing a high level chart documentation analysis. So what
Mm-hmm.
does that mean? We're not looking at did you sign this? And that's in for us in my company, that's QAPI. So in QAPI, we're looking for the technical part of it. And in QA, we're really looking at your visit note. And when we're analyzing it and we're making sure everything it's being reviewed just like a surveyor or a medical record reviewer would for CMS. So we're analyzing it. We're not just looking to see if a sentence is missing. We're looking at the full story. Does plan of care matches what you have documented? Is there consistency between what you're checking off the box and what you're writing? We're looking to see, does this tell the full story of the patient? So essentially, we're looking to see if the chart is defensible. It's defensible, whoever's looking at it.
Mm-hmm. Mm-hmm.
And then in the QAPI, we're looking at all of your consent form, all of your research, your frequency of visit, is the time. If you said you're going to see the patient 3 times a week, are you really seeing them 3 times a week? So, and there is there documentation to match this 3 times a week visit.
Mm-hmm.
So when I send out reports to the organizations, there's always a shock, a full blown because shock because we're sending multiple. When I'm sending the results, it's multiple pages of correction or the consent form that will like, well, page one, the checkbox is not there. Page two, and it's always like, really, this is. I'm like, well, that's what we do. All we
That's
do
what.
all day. Just same way you guys all see patients all day. All that we do all day is look at
Mhm.
records, and we're pinpointing all the areas that could essentially be an issue for you. And as someone who's doing multiple ADRs a day, I'm always doing some sort of when I say ADRs, just to clarify, I'm sure no one knows what that is. Usually ADRs are additional record requests that Medicare would want to see
We
after they've
want.
paid you. After they paid you, now they're
Mhm.
saying, "Oh, by the way, I want to see this claim that I paid for $10,000. I
Mhm.
want to see this record that I've paid you from 2 years ago."
Only two.
From 2 years ago.
Mhm.
So now we have to review records for 2 years ago. And for me, I'm always amazed of the denial, what they would document, what they would write in those denial. And you get to really get an insight of how they're looking at the record. And as a former surveyor, I understand that's how any one surveyor would look at the record and findings. But the difference between a surveyor and the MAC auditor is the fact that you can lose revenue, right?
Yes.
So, and this is revenue where you've already paid those nurses for this work, you've already paid those, so everyone already got paid. And now they may easily say, I just did an ADR for a client where they wanted to, when we added up all the claims, $780,000 just for 10 patients. Then 3 years, they want 3 years back. So could you imagine
Yeah.
$780,000? That could shut down an agency. A
Yeah.
small organization can be shut down. So
Yeah.
when we talk about QA, when we're talking about QAPI, these can make or break your agency. So this is why specifically now. Now, I mean, in the days when I was doing hospice years ago, you could, do a little QA here. Now, it's not a if I'm gonna be surveyed, is when. Everyone should literally be sitting down and waiting for their letter because it's coming. If
It's
not
coming.
now, it's coming. So you have got to make sure your documentation is right and tight. and that your nurses understand why now you are QAing differently. Because you may have nurses who've been with you for 10, 15 years where you never ask them to do anything.
Yeah.
No one said anything. No one mirrored anything. Because I'm coming in, I'm coming in with like, oh, why is she? Who is she? Nurses where I am do not. A lot of them have a hard time. And I think I posted this yesterday, just not long ago. I had an aha moment with some of this from some of the nurses when we told them what we review. Because the idea was always, oh, I'm just looking at their visit note today. I'm like, no, I'm looking at everything. The way you should be looking at the record, that's how we look at the record daily during your visit. So it was just like, okay, I see why. I see what you're looking for. I
Yeah.
understand what you're saying.
Yeah.
So there's a lot of aha moments. So we come in, we're not just there to save the agency. For me, I always say I'm a nurse's nurse. So I always make sure that I'm not sending tedious city things back to you. I'm sending you something that I know that if we're standing anywhere, I want to you'll be able to defend what you
What's it?
documented. You'll be able to
Mhm.
defend the patient. You'll be able to helping defending the agency can defend themselves. So that's the type of QA I do. It's all about defensibility, making sure it could stand anywhere, whether it is now, whether it is 5 years from now. Whoever opens up the chart, if a record is reviewed by myself and my company, I know that that record is being reviewed properly. And with that, it's not just review that we do. Once we send out the correction to you, the record comes back to us. So a lot of the EMR, it's that first part, is the part where the record comes to us, we review it, we send it to you, it comes back again to us for us to re-review to confirm that the
Mhm.
correction was done. So it's a it's
Mhm.
a it's a loop that gets open and we close it. In that part where we're reviewing to confirm that it's done, that's that piece that's even
For clinician.
more important than me sending it back to you sending it to you for correction.
Yeah.
So
Yeah.
in that piece, once we approve it, that second time around, believe me, that record God down can come down and say, why is this patient here? God will be able to tell you, yep, Irene did this, it's good.
So we talked earlier about it's being a systems issue nine
Yeah.
times out of 10. So with that in mind, if you had to give advice to, I know that the advice will have to be different depending on the level, but I'm going to give you three people, a nurse,
Mm-hmm.
a CEO, and a
Mm-hmm.
DON. What kind of advice would you give to those three?
So a nurse, I would say, don't chart to impress, chart to explain. Your assessment matters, and you need to learn how to convert that assessment into a proper narrative. For a director of nursing, fix the system, not just the note. Invest in education before survey forces it. So invest in education. When you are a DON, you need to make it your business to understand COPs, condition of participation, condition of
Yeah.
payment, how hospice and home health is what it is. Why are we here? How do we make sure we sustain this? You cannot just run around and just trying to fix notes, trying to audit notes. You got to fix the system. You have got to fix the system. Because if you don't fix the if you don't go to the root cause of why we have a problem, you'll nothing will ever change. For the CEO, I would say visibility beats crisis management. And ongoing QA costs less than last minute correction. Ongoing QA costs, and I say this, whether you're doing internal QA, whether you decide you want to work with me or someone else, ongoing QA costs less than last minute correction. It is important that you invest into ongoing QA. That is what's going to keep, not even, I'm not saving, not even save, keep your organization, right, for many
Yeah.
years to come. Because
Yeah.
if you have someone who's really good, if you have your DON who understands not all, and I don't mean, when I say understand, I don't mean that you need to know everything. All of this information is in your policy. And I make fun of this sometimes. Like I tell leaders when I sometimes do some coaching with DONs, and I'll say to them, use the policy like a book. Sometimes when you get home, you're relaxing, you've done, take care of your kids, read a couple of pages and just pull the main ones. And I always say the main ones are your assessment, main policies, your assessment, your plan of cares, medication management, medication reconciliation, and then understand what QAPI is, understand pain and all of the different one that deals with symptoms, and then understand your LCDs. You should always have a copy of all of the LCDs, which is the local coverage determination specifically for hospice. You need to have a copy of that on, like, in your desktop, your laptop, wherever, for you to have access to it at all times. So I'm not even gonna go into you getting a copy of the COP. That's next level, but yes, you should have one. You should have a copy of the COP. You need to understand at least basic of hospice. So that would be my advice for each person. Chart to impress, don't chart to impress, chart to explain. You need to be explaining. Directors fix the system, not just the notes, and invest in education, because believe me, surveyors will get you there. And then the
Yeah.
CEOs, ongoing QA costs you less than last minute corrections.
Awesome. 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 So, lastly, the mindset shift for everybody would be
Compliance isn't about fear, it's about clarity. That's what I would say. Okay? It is about clarity, 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 clarity. And when a nurse or any discipline understand why, documentation then becomes protection, not pressure. Because that's what documentation is. It's protection. But we need to change our mindset into thinking
yes.
compliance as clarity.
Thank you so very, very much. On that note, Irene, thank you so much. There was so much in that conversation,
Thank you
so
so
many
much.
gems in that conversation. Thank you so very much. I cannot tell you how much I've enjoyed it.
Thank you, Ms. Dell. Thank you so much.